Hello, you are most welcome, ladies and gentlemen, to the Understanding Spirit of Anatomy on Tuesday Night Anatomy with Daniel Okwan. Today's section is going to be a quick revision on bones of the lower limb that we've already looked at, as well as its girdle, being the pelvic girdle. I'm going to do this revision with you through some questions. Of course, will help you get the correct answers, and those which are incorrect, we justify why they are not correct. And so, without much ado, let's set the ball rolling. And we begin with question number 1. And question number 1 says, which of the following is false about the lower limb bones? Now, option A says, the innominate bones, that's the os cruzi, which are part of the bony pelvis, are connected anteriorly by the symphysis pubis. Yeah, this is actually a very true statement that yes, anteriorly, the left and right hip bones will be connected by what we call the pubic symphysis or the symphysis pubis, which is actually a fibrocartilaginous, joint. Of course, posteriorly, they will be connected via, of course, the ala of what we call the sacrum. We will look at those ones. Now, option B says, the gynecoid type of pelvis is suitable for transvaginal childbirth or parturition. Now, this is a very true statement. We will get to know that yes, apart from the gynecoid, yes, we have the android, the anthropoid, the platyploid, type of pelvis. But of course, the suitable one, the most suitable one for, childbirth through the vagina will be the gynecoid type of pelvis. And we look at those important features. Option C says, the hamstring muscles originate from the ischial tuberosity, the sit-down portion of the pelvis. Now, this is a very true statement. You get to know that, yes, as part of the bones of the pelvis, the innominate bone will consist of 3 bones. Yes, the ilium, pubis, and ischium. Now, the ischium will bear a tuberosity, on its body, and that tuberosity is known as ischial tuberosity. And that is where, if you want to sit, that's where you sit on. And that becomes also an important origin for muscles of the hamstring group of muscles, actually. So that's a true statement. Option D says the pelvic brim, which delimits the superior pelvic aperture, is formed by the iliac crest, pectineal line, arcuate line, ala of sacrum, and sacral promontory. Now, this is actually a very true statement. Yes, we will get to know that if you look at the pelvis will have what we call the greater pelvis and of course the lesser pelvis. Above this pelvic brim, will be the greater pelvis or the false pelvis, and this pelvic brim actually serves as the boundary or the landmark for us to get what we call the superior pelvic aperture or the pelvic inlet. Now, the superior pelvic aperture is the same as pelvic inlet. That's a very true statement, and this pelvic brim is actually formed by the iliac crest. Yes, that's true. The pecten pubis, that's the pectineal line, the arcuate line, yes, of course, ala of the sacrum, and of course, the sacral promontory. These are very important. We will look at that. Now, option E says, while the obturator canal is formed when most portion of the obturator foramen is filled with obturator fascia, greater and lesser sciatic foramina in the living through sacrospinous and sacrotuberous ligaments are formed from greater and lesser sciatic notches. Now, this is a false statement. Now, the only false statement in here is that yes, we know that obturator canal will be formed from obturator foramen when this obturator foramen, most of it is filled by obturator membrane, not obturator fascia. Obturator membrane actually covers what we call the obturator internus muscle and not this obturator foramen. So it's rather obturator membrane. Yes, the remaining statements are true that greater and lesser sciatic foramina, yes, will be formed through, of course, these ligaments, sacrospinous and of course sacrotuberous ligament. We look at those ones. So this is the false statement, option E. Let me justify it. Now, if we look at the pelvis, the pelvis, as you can see over here. Now, what I'm seeing right now is the bony pelvis. Now, there's a difference between the pelvic girdle and bony pelvis. If you talk about bony pelvis, then you have to include the sacrum and of course the coccyx. But these left and right bones over here, these irregular shaped bones over here represent what we call the bones of the pelvis or the os cruzi. So if you take the os cruzi, although I'll go through the various details, but we have the superior portion being the of course, the ilium, being what we call the ilium, and of course we have two inferior bones. The anterior inferior bone is what we call the pubis, and the posterior inferior bone is what we call the ischium. And the ischium, I'll show you that that's the portion that we sit down on. That area, the roughened area over there, is the ischial tuberosity. We'll look at those ones. But for now, what I want to show over here is that we have what we call the pelvic brim. Now, this is the pelvic brim over here. Now, the pelvic brim will be formed by, of course, the iliac crests. Okay, will contribute to the formation of the pelvic brim. Yes, to get in the midline. Yes, of course, we are going to have the pubic symphysis. So, iliac crest and pubic symphysis over here. Then, of course, on the ramus, I will show you all these parts later. We have, this is the body of the pubis. The body of the pubis emerging from the superior aspect. We have superior pubic ramus and then we have inferior pubic ramus. On the superior pubic ramus, what happens is that we have, a line which we call it pectineal line or the pectin pubis. And then also on the body, okay, as you move, get into the body of what we call the ilium, we also have another line which we call the arcuate line. And then of course, this is the sacrum. On the sacrum, we are going to have the wing. Okay, so there's the ala of the sacrum, the ring of the sacrum also contributing to it, and of course the most anterior projecting portion of the sacrum at the base of the the sacrum being what we call the sacral promontory is also part of the pelvic brim. Okay, also part of the pelvic brim. Now this landmark gives us the boundary of what we call the superior pelvic aperture or the pelvic inlet. Okay, so that is what I want to actually show you over here. Now, if we've talked about pelvic inlet, then it also makes sense that we talk about pelvic outlet. Now, so if we talk about pelvic outlet, yes, just like the pelvic inlet boundaries, but let me show you something. Let me show you something in the previous way. Now, if I've got this pelvic brim, then we're saying that above it, most of the abdominal organs, lower abdominal organs, will dwell here, and therefore we call this area the greater pelvis. And deep to it inside, we have what we call the lesser pelvis. Now, the greater pelvis can also be called the false pelvis, and of course, the lesser pelvis can also be called the true pelvis, because of course that is where the true pelvic organs, talk about the genitourinary structures, will be there. Okay, so that is what I want you to know. Now, so having seen the pelvic inlet, then we want to also see the pelvic outlet. So the pelvic outlet will also have these boundaries, although I'll take you through these important details once again. And those boundaries, yes, anteriorly we are going to have the pubic symphysis together with, of course, the body or the iliac crest. Okay, the body of the pubis. So that's what we are going to have. And then of course there's a ramus. Okay, there's a ramus. Now this ramus over here, now look at this. I want to show you from here. Now this is the body of the pubis. This is the ischium. The ischium presents with one ramus, but the pubis presents with a superior ramus and an inferior ramus. The inferior ramus of the pubis and ramus of the ischium form what we call ischiopubic ramus. So this over here, okay, anterolaterally of the pelvic outlet, we are going to have ischiopubic ramus. Okay, then on lateral aspect, so laterally we are going to have what we call sacral promontory. Okay, so these are the sacral promontory that we are going to have over there. Then posterolaterally, there's going to be a ligament. I will show you that ligament. Okay, that ligament was spanned all the way from what we call the ischial tuberosity all the way to the sacrum and the coccyx, and that ligament will be called sacrotuberous ligament. On either side. And then the most posterior structure will be the tip of the coccyx. So these ones represent the boundaries of the pelvic outlet. So that is what I want you to know. Now, so we have, with respect to the pelvic outlet and of course the pelvic inlet, we will have what we call some dimensions that we can actually determine. So for instance, from anterior posteriorly, okay, and anterior posterior with respect to the pelvic inlet and of course pelvic outlet, those things will have to be measured so that we can actually assess if, for instance, an individual can give birth through the vagina. Okay, and that is why we look at the various types of pelvises. So I'll go through those ones with you. Otherwise, there's likely going to be something we call pelvic disproportionation, such that yes, the head of the fetus may be too large to get out of the birth canal through, of course, this pelvic outlet that we are talking about. Then of course we also have the diameters on either side. Okay, so from lateral to the other lateral aspect, that dimension is also very important. So these are the things that I want you to know here. So having seen generally what this pelvis is about, yes, we have to be able to distinguish between the male and the female bony pelvis. Now this time bony pelvis, not just the pelvis alone, bony pelvis. So as we can see, yes, in the case of the female, there's going to be a broad pelvic cavity. It's supposed to be broad so that the diameter from left to right, yes, is greater compared to that in the male, as you can see. However, with respect to the height of this this cavity, what we find is that yes, for the males it's going to be deep. The cavity will be deep compared to that of the female. That's what we want you to know. And then of course, generally for childbirth, we expect that females should have generally an oval or rounded shaped what you call pelvic inlet, pelvic inlet. And then for that of the males, it's going to be usually heart shaped. Now generally males would tend to have heavier bones as well as greater muscle mass compared to that of females, and that is why we expect that if you take the weight of this bony pelvis in male, it will be greater compared to that of the females. And then of course, when you look at, there's an angle over here which you call it the sub-pubic angle, or simply the pubic angle. That pubic angle over here will be more than 90 degrees in case of females, but it will be less than 90, around 70-80 degrees in the case of males. That's what we are going to see. Then again, to ensure smooth delivery through the pelvic outlet, then what happens is that this sacrum and coccyx in case of females is less curved anteriorly, but in the case of males it is more curved. That's another thing too that I want you to know. Then of course, if you look at the ischial tuberosities, what we find is that for the ischial tuberosities in females, it is more everted. It is getting the outside part of the middle of the body. But in case of the males, it is more inverted. It is more medially oriented. So these are some bits of differences that we can have with respect to the male and the female pelvises. Now, having seen the distinction between the male and female pelvises, generally, what happens is that yes, there are other types of pelvis that females will also present with, and that is what we call, yes, the commonest one, which we are going to find about 50% of females, is the gynecoid type. And that in the question you saw that this one is going to be very suitable for transvaginal delivery. Why? Because we are going to see that yes, its pelvic inlet will be rounded, will be generally rounded, or if not rounded, yes, slightly oval, and then you can see that it's the pelvic cavity will be more roomy so that it can accommodate the fetus, will be more roomy over here. And then of course, with respect to the pelvic outlet, it is also wide. So one thing too that you have to know with respect to the difference between male and female pelvises is that with respect to both pelvic inlet and pelvic outlet, yes, both of them will be wide. That's what we are going to see in case of the female than in the male. So that is what we are going to see. But one other thing too that you have to know, now look at over here, these represent what we call the ischial spines. I'll take you through these ones. These represent what we call the ischial spines, coming from the ischial spines. Now these ischial spines, you can see that compared to the other ischial spine that you find in the remaining part of the pelvis, now compare these ones, you can see that this one is less prominent, or the least prominent among all these types of pelvises that we are going to have. And then of course, although we can't see it over here clearly, there's going to be a wide sub-pubic angle. As I told you, there's going to be a wide sub-pubic angle. And then of course, yes, if you look at the sacrum and the coccyx, it will be less curved anteriorly. So this is the commonest type of pelvis that you are going to find in females, which will be very relevant as far as transvaginal delivery is concerned. Now the other type which follows this gynecoid type is the the word gyne has to do with female, has to do with female. The next one is anthropoid. Now anthro has to do with human being, so it has to do with human being type of pelvis, and this one you're going to find it in about 25% of females. Okay, and one thing that we are going to see is that yes, apart from having some features which resembles that we want to see in the case of female, the important bit that you have to know is that it's going to have a long oval inlet. Okay, so its pelvic inlet is going to be long and it's going to be oval. Now why am I saying it's going to be long? Now from here, from anterior to posterior, it's going to be long compared to what we find in the case of the gynecoid type of pelvis. Okay, so that is what I want you to know. But of course, if you look at the sacrum and the coccyx, that one too, yes, it is quite narrow, or let me say it is less kept actually. That's what we are going to see. Then yes, ischial spines are relatively greater compared to that you find in the case of course the sub-pubic angle will be relatively shorter, okay, reduced compared to that one in the gynecoid type. So finding itself in about 20% of females is the android type. Now anytime you hear the word android, then it has to do with the male. So it means that yes, there are some females which present with some male features type of pelvis. Okay, why? Because look at this pelvic inlet, it's roughly heart-shaped. That's the one we expect to see in that of males. You can see that its sacrum is also prominent, its ischial spines are also prominent. Okay, and then of course, because it is going to have the male type of pelvis, its sub-pubic angle will be reduced relatively. Okay, and then finding itself in roughly 20% of females. And in fact, there is also the one which is also less common, yes, in both sexes. That's one thing that you have to know. Yes, but it's finding itself in about 20% of females. And this is what we call the platypuloid type of pelvis. Now, the word platy has to do with flat. Okay, so what happens is that yes, it's going to have its pelvic inlet is slightly flattened, or it's going to present with a kidney-shaped kind of pelvic inlet, kidney-shaped type of pelvic inlet, not heart-shaped, kidney-shaped. And then one other thing too is that yes, if you look at the diameter, okay, from side to side, you can see that it's roughly having the greatest type of diameter, okay, from side to side. This platypuloid type of pelvis is going to have that one. And then of course you can see that yes, it's having quite prominent sacral promontory, sacral promontory, as well as of course pelvic the sacrum and the coccyx is also oriented a bit anteriorly. Then of course you can also appreciate the ischial spines, but they are less prominent compared to the android type of pelvis. So these are the things that we have to know. Now one thing too that I want to actually show you over here is that now if you look at one bit of the pelvis, yes, this one is the the right pelvis or scusa. Yes, we are going to find that we are going to have three bones. These three bones are the superior bone is what we call the ilium. Then we are going to have two inferior bones. The inferior bone where is anteriorly oriented is the pubis, and then the posteriorly oriented one is the ischium. Now the superior bone over here, I'll show you other things. Yes, we are looking at the gluteal surface. Okay, so that region which of course the gluteal muscles are going to find attachment to. So this is the gluteal surface. Now on the gluteal surface, now one thing I have to tell you is that if you take the ilium, it's going to present with the body, and then of course an ala. It's going to present with the body and an ala. And when I say ala, it's wing. So there's the wing of the, so yes, the body is a bit smaller, the wing is quite broad, as you can see over here. Now there are some important features that we see on the body as well as on the ala of the gluteal surface of the ilium. And those things, yes, we are going to find what we call the anterior, yes, we are going to have inferior and of course posterior gluteal lines. Okay, so of course I will show you some important muscles which I will get a slide to show you those ones. But this is going to present with what we call the iliac crest. This is the iliac crest. Now on the iliac crest, you are going to have the outer lip, because the outer lip is more closer to where the gluteal surface is. So this is the outer lip. Then we have the intermediate zone, and then of course we are also going to have what we call the inner lip. I'll show you the inner lip when you look at the pelvic surface or the inner surface of the ilium. Then as you descend, as you move, okay, from the posterior aspect, you run your finger along the iliac crest. What happens is that, yes, we present with this, bulge out, region over here, which you call it the iliac tubercle. Then, of course, as you descend anteriorly, we are going to present with this spine, which you call it the anterior superior iliac spine. And then, of course, if you go to a lower level, we are going to have anterior inferior iliac spine. I'll show you these important attachments pretty soon. Then, of course, if you go posteriorly, similarly, we have posterior superior iliac spine, and of course, posterior inferior iliac spine. We will get to know that there will be a tuberosity, which will be in the inner surface. So I'll show you that one. That will be the iliac tuberosity. Okay, so this is what we are seeing over here. All right. Now, then we also have the pubis. Now, if you take the pubis, we are going to have, yes, the body of the pubis. We are going to have the pubic crests. Okay, pubic crests will be a bit medial. Then going lateral, we are going to have the prominence being the pubic tubercle. Now, emerging from the body superiorly will be the superior pubic ramus. Now, ramus is going to be branched, so it means that if you take the pubis, it's having a body which will bear, of course, the crest and tubercle, and it will present with two branches, a superior pubic ramus and an inferior pubic ramus. Then we also have the other bone, and the other bone is the ischium. The ischium, yes, of course, will present with the body. Then, of course, it will present with a single ramus. Now, the ramus of the ischium combines with the ramus of the pubis to form what we call the ischial pubic ramus. And that is what I told you will form one of the boundaries of what we call the pelvic outlet, being the posterolateral boundary of the pelvic outlet. And then, of course, on the body, the sit-down portion is what we call the ischial tuberosity. And this ischial tuberosity will be an important, origin for what we call the hamstring group of muscles. And these hamstring muscles are muscles of the posterior compartment of the thigh. Okay, so that is what I want you to know over here. Then as you project superiorly from the body, okay, the ischium presents with the spine. So there's the spine of the ischium. This spine of the ischium is able to give us two important landmarks, and one of them will be above the spine, and therefore we call it greater sciatic notch. Okay, greater sciatic notch, and then below the spine will be a smaller, lesser sciatic notch. Okay, so that is what I want you to actually know over here. Now, what we find is that, yes, over here, all these three bones are fusing in this area. So it means that all these three bones are contributing to this structure over here, which we call it the acetabulum. Okay, so this is the acetabulum. Now, the acetabulum will present with a margin or a rim, which we call it acetabular margin, or the limbus of the acetabulum. And then, of course, it will present with a lunar shaped or a moon shaped region, which we call it, the lunar surface of the acetabulum, or that's the lunar surface of the acetabular cavity. So that is what I want you to actually know over here. And then, of course, this acetabulum cavity, yes, in the living is deepened so that the head of the femur can fit in here, and that is what we call the acetabular labrum. Now, over here at the lower aspect over here, there's a notch over here, and that's what we call the acetabular notch. Okay, so that's what I want you to know. Now, this acetabular notch or this acetabulum will contribute, as well as, of course, the rami of what we call the pubis, ramus of the ischium, and of course the body of the ischium will contribute to the formation of this foramen. And this foramen is what we call the obturator foramen. Now, I will show you that in the living, obturator foramen will be filled by what we call obturator membrane, not obturator fascia, obturator membrane, leaving a small opening. I'll show you these ones. Okay, so that is what I want you to actually know over here. I'll show you some important muscle attachment, but of course, for now, what I want you to know is that, yes, if you take the anterior superior iliac spine, apart from the longest muscle being the sartorius muscle originating here, We also have what we call the inguinal ligament, also taking attachment here. Then of course, anterior inferior iliac spine, yes, who provide origin for what we call the rectus femoris muscle. You know, in the what we call the anterior compartment of the thigh, yes, we are having those kind of 4 muscles over there, the quadriceps group of muscles. Those quadriceps muscles, yes, one of them being of course the rectus femoris, is taking origin from high above here. Okay, and that is this one being of course the rectus femoris, actually the straight head of rectus femoris. Then a reflected head, yes, who originates just above this acetabular margin over here. All right, so that will be what we call the reflected, head. Then of course, if you look at the iliac crest, you know that the iliac crest will be very important, attachment origin of muscles, except only one muscle, which will be the external oblique muscle, which will actually insert here. The other muscles will actually, yes, originate here. Yes, talk about, internal oblique, talk about transversus abdominis. I'll show you these ones. Talk about erector spinae as you get more to the back. Talk about gluteus muscle. Yes, they all originate in the back over there. Okay, so these are some important bits that I want you to know over here. Now, this is the inner surface of the pelvis, because this one we are not seeing the gluteal lines. Okay, but on the ala of the sacrum, you can see this large fossa, and this is what we call the iliac fossa, where of course the iliacus muscle will be taking attachment here. So this is actually the inner lip that I was talking about, the intermediate zone, and the outer lip will be more towards the gluteal surface. Then if you look at over here, get to the rear aspects of the ilium, okay, ala of the ilium, the inner aspect, you are going to find this tuberosity over here, and that's the iliac tuberosity, the roughened area over here. Okay, and then of course just below that you are going to have the articular surface for of course the ala of the sacrum over here. So that is what I want you to actually know over here. Yes, the remaining portions I've actually explained all these ones over here. All right, now so I told you that yes, if you use this this pelvic brim as a landmark, then above it we are going to have what you call the the greater pelvis or the false pelvis, and below it we are going to have the true or the lesser pelvis. Now remember, I told you that the obturator foramen will be filled by a membrane which we call it obturator membrane, leaving superiorly a small opening which will allow the passage of course obturator nerve and vessels, okay, to run through it. But of course that one is what we call obturator canal over here, and not obturator fascia, because another muscle which will be taking an attachment from the adjoining bone over here, as well as of course this obturator membrane, will be what we call obturator internus muscle, because this is the inner in the pelvic surface, and that one, its fascia will be the obturator fascia. Therefore the obturator fascia is not the same as obturator membrane. Okay, so that's what I want you to know over here. Then of course I also told you that we are going to have projecting from the body superior from the ischium will be this ischial spine, so that we get a greater sciatic notch, lesser sciatic notch. But in the nervine there are 2 muscles. Yes, the deeper muscle is taking attachment from the spine of what we call the ischium all the way to the sacrum and the coccyx. That one is what we call sacrospinous ligament. Based on the attachment, this is the sacrum, and of course this is the spine. So sacrospinous ligament, and another triangular shaped ligament which takes attachment from of course the ischial tuberosity all the way to of course the sacrum and the coccyx. That one will be called sacrotuberous ligament. Okay, that one is superficial to this sacrospinous ligament, so that they can convert these 2 notches into the respective foramina, So these are some important things that I want you to know by way of some important information. Obturator internus muscle, that muscle over here, will actually exit what we call the pelvis and insert on what we call the femur. Okay, insert on the femur laterally. Yes, is going to be what we call the what you call obturator internus muscle. So it will leave it through the lesser sciatic foramen, but piriformis will leave and yes insert on lateral aspect, actually on the greater trochanter of the femur via of course the piriformis, via this greater sciatic foramen. So these are some important things that I want you to know. So I told you that yes, the pelvis, there's going to be this acetabular cavity, which of course the head of the femur will have to fit in, but this cavity is even further deepened by a fibrocartilaginous rim known as acetabula labrum. Yes, of course, you know there's a ball and socket joint. Yes, you can visit those videos of mine on joint to get more insights in these ones. Yes, I'll actually be going through, do a revision on the joint that we've done already. Yes, now, so these are some important muscle attachment that I told you of. This is actually the gluteal surface. If you look at the gluteal surface, then of course, between of course the anterior and inferior gluteal lines, taking attachment there will be what we call the gluteus minimus muscle, and then between of course the anterior and posterior gluteal lines will be the origin for gluteus medius, and behind or posterior to of course the posterior gluteal line will be the origin for what we call the gluteus maximus muscle. Of course, we know that the piriformis will be originating from of course the sacrum, but what happens is that some of the fibers will originate at the rear aspects of what we call the pelvis, of the ilium of the pelvis actually. Then of course I told you that anterior superior iliac spine, sartorius, and then of course the inguinal ligament. Then also told you anterior inferior, for of course rectus femoris muscle, actually the straight head, and then of course just above this acetabular margin will be the origin for the reflected head of rectus femoris muscle. Then I told that all muscles which are going to attach on the iliac crest will actually originate, except the external oblique muscle, which will be inserting there. So as you can see, tensor fascia lata, talk about internal oblique, talk about transversus abdominis, talk about latissimus dorsi. Okay, all of them, erector spinae, will all be originating there. Then if you look at the pelvis, the pubic area, you can see the pectineus. This is the pelvis area. So pectineus, superior pubic ramus in there. Then we also have what you call rectus abdominis muscle. Yes, of course, it's going to actually, originate from what we call the pubic crest. Pubic crest over here. That's what we are going to see over here. Then of course you can see the adductor longus muscle, the piriformis muscle. All these ones are actually originating around the body of the pubis. Then of course the medialmost muscle in the medial compartment of the thigh being the gracilis muscle. You can see that's where it's going to originate. Then adductor brevis, obturator externus. All these, the obturator externus, you can see this is the gluteal surface of the pelvis, and therefore you can see that there's this obturator foramen over here. I told that in the 11 will be covered by obturator membrane. Taking an attachment externally will be of course obturator externus muscle. Then I told you that the ischial tuberosity will be important origin for what we call the quadriceps groups, for what we call the hamstring group of muscles, and they are of course the semitendinosus, the biceps femoris, of course semimembranosus, of course all these ones will be originating from here. Then of course one of those deep muscles in the gluteal region, the quadratus femoris over here. So remember there's a difference between quadriceps muscles. So quadriceps muscle, I'll show you those ones. There's quadratus femoris, then adductor magnus, all originating around this area of the ischium. Then of course superior gamillae, inferior gamillae. Superior gamillae, gamillus muscle will be coming from of course the ischial spine. So that is what these are some important muscle attachments. Then if you look at the pelvic surface, I told that iliacus in the iliac fossa will take origin from, you can see transversus abdominis, from the what do you call it, the iliac crest. You can see quadratus lumborum, all these ones. Now there is a roughened area where sacroiliac ligaments will actually attach over here. And then, of course, I told you of the coccygeus muscle. Yes, coccygeus muscle also coming through. It's actually ischio-coccygeus muscle. The proper name for coccygeus is ischio-coccygeus. So coming from the, ischium. Okay, so these are some bits. Then I've told you of obturator internus muscle, how it's going to originate from the inner surface of the adjoining bones of forming what we call the obturator foramen, and of course obturator membrane, inner aspect. Then of course superficial perineal, transverse perineal muscle, yes, sphincter uretary, you can see those ones from the lower aspect. And of course levator ani, the anterior portion of the levator ani will also be, of course, this will be the pubo, coccygeus muscle, pubo-coccygeus muscle. So these are the things. Yes, psoas minor will be, yes, attaching over here on what we call the junction between, of course, the pectineal line and of course the arcuate line of course the pelvic brim. Okay, so these are, some important bits that you have to know. Now, to give you additional information, one thing that, yes, we have to know is that, yes, the pelvis, okay, we're gonna have what we call one, because there are 3 bones over there. Each bone will have a primary ossification center. Okay, so each bone of the pelvis, so if you take the ilium, it will have one primary center of ossification, and that one will appear in the 2nd to 3rd month of intrauterine life. Okay, 2nd to 3rd month of intrauterine life, that's when the primary center will appear. And then of course appearing in the 4th to 5th month of intrauterine life, the primary center in the ischium will appear. And appearing, yes, around the 5th to 6th month of intrauterine life, yes, of course, the primary center of the pubis will appear. Okay, so these are the primary centers. Now, with the exception of what we call the ilium, which will have 2 secondary centers, the remaining ones will have, of course, 1 secondary center each. Okay, we'll have 1 secondary center each. Sorry, let me just show you this. Now, the 2 secondary centers coming from, of course, the ilium will be on what we call the iliac crest. Okay, and that one will appear around puberty, yes, 12, 13, 14 years, around puberty, and to get fused by age 25. Okay, that's what we are going to see. And then for the secondary center that we are going to find on the ischial tuberosity, lower aspect of the ischial tuberosity, yes, will appear also at puberty and to get fused by age 25. Then there will be, yes, we can see a secondary center in the case of the pubis, but in the Y-shaped triradial cartilage that we find in the acetabular cavity, yes, that one will appear also at puberty. There will be 2 secondary centers in there and to get fused also by age 25. This is some kind of bit of information that I want to give you. So let's go to question number 2, and question number 2 says, which of the following is not true about the lower limb? Now, option A says, the longest, heaviest, and strongest bone in the human body presents proximally with a medial head, lateral greater trochanter, and a posteromedial lesser trochanter. Yes, this is actually a very true statement. I'll show you that. Now, option B says, just above the medial epicondyle is the adductor tubercle, which provides attachment point for the adductor magnus muscle. Yeah, this is actually a very true statement. You get to know that, yes, just above the medial epicondyle, we have what we call adductor tubercle for adductor magnus muscle. Yes. Option C says the patella, which literally means little dish, is roughly a triangular shaped sesamoid bone which develops in the tendon of the quadriceps femoris muscle. Yes, this is actually a very true statement. Yes, it will develop in the tendon of the quadriceps muscle. In the tendon of the quadriceps muscle. Sorry, over here it says in the tendon of the quadratus femoris muscle. Now, this is a wrong statement. It is not quadratus femoris. It is quadriceps femoris, not quadratus femoris. Quadratus femoris is a deep muscle which you find in the gluteal region. It is not going to be this one, so I'm going to justify it for you. Option D says the runner's knee, otherwise known as patellofemoral stress syndrome, produces painful tracking of the patella laterally. Yes, this is a very true statement. It always causes it to move laterally, okay, and it's quite painful in there. Option E says the gyros muscles insert on the medial aspect of the proximal shaft of the tibia. Now this is a very true state, although we know that yes, the medial border of the medial surface of what we call the tibia is subcutaneous, such that there's no muscle actually inserting or attaching there. But if you come to the proximal aspect, yes, 3 muscles, although they are all coming from different compartments, they are going to insert there. I'll show you this one. Those muscles are those we refer them as the gyrus muscles. So there we are. This is the longest, the heaviest, yes, and of course the strongest bone in the human body, yes, by way of length, roughly 45 centimeters long. Yeah, so that's what we are going to see. Now this bone proximally, okay, presents. Now this is an anterior view, so because we are seeing the anterior view, we don't see this what do you call it, distally we don't see this fossa, intercondylar fossa, okay, but we can see the patellar surface, and of course we can also see a line between. So let me explain to you. So if you take an anterior view, this is the tibia, this is the femur, and proximally oriented medially is the head of the femur, and then you can see that the head presents with a pit, and that's what we call fovea capitis, and it has this rectangular shaped neck, which you call it, yes, the neck of what we call the femur, and then placed laterally, because I told that the head orients medially, so placed laterally, superolaterally actually is going to be what we call the greater trochanter, and placed a bit at an inferior level, but actually posterior medially will be, of course, the lesser trochanter, because you can see, if you look at the posterior aspect, it's more pronounced, so posterior medially. And then connecting them anteriorly will be a line, which we call it intertrochantelic line, but posteriorly will be a crest. It's more elevated, and this is what we call intertrochantelic crest. Then of course, yes, there will be a trochanteric fossa in there, okay, there will be a deepened area which you call a trochanteric fossa in there. Then of course there's the shaft. Now anteriorly, the shaft, you can see, if you look at it laterally, what happens is that it is convex anteriorly but concave posteriorly. Now the posterior aspects present with this line. Now laterally placed, yes, laterally placed will be that for the gluteus maximus muscle to actually insert here. So there's going to be that kind of gluteal line over there, a gluteal line, or gluteal tuberosity, actually gluteal line over there. And I also have what you call the pectineal line also there, and as it descends, it gives us these 2 lips, okay, posteriorly, and those lips represent what we call lateral, and of course the medial supracondylar lines, okay. So what happens is that, yes, at the distal aspect, we are going to have the patellar surface. It's going to present with 2 condyles. Of course, this will be the lateral condyle away from the head, and of course in the direction of the head we are going to have the medial condyle, and then just above these condyles we are going to have what we call the epicondyles, respective epicondyles. But above the medial epicondyle we are going to have the adductor tubercle, which of course we said that will be the insertion point for the adductor magnus muscle, okay. So that's what we are going to find. Now posteriorly, there's going to be what you call intercondylar fossa between the 2 condyles, okay. That's what we are going to actually see over here. So this area is actually the popliteal surface, and this is the patellar surface, okay. So actually, if you take the bone, then if you take a cross section through it, then what we are saying is that, yes, we are going to have the posterior surface, we are going to have, of course, the medial surface, okay, medial surface, and we're also going to have, of course, the lateral surface, okay. And of course the posterior surface will present with this line, which goes posterior inferior to give us these 2 lips. That's the linea aspera, okay. So that is that for you. And of course I told you of the pectineal line, I told you of gluteal tuberosity, linea aspera, and of course giving us these 2 lips. I'll show you more of these ones. So there we are. If you look at the anterior aspect, you can see that on the greater trochanter we can see some muscles inserting there. Talk about gluteus minimus and of course the piriformis muscle. Okay, they are going to insert over here. Then of course, if you look at the lesser trochanter, yes, of course the psoas major iliopsoas tendon will actually insert there. Okay, I told of the fovea capitis in there. Then of course you can see the vastus lateralis and vastus intermedius also taking attachment at proximal aspect of, so just below this greater trochanter will be of course the origin for what we call the vastus lateralis, and of course just around where we have the intertrochanteric line, we are inferior aspect of intertrochanteric line, we are going to have the vastus medialis actually, yes, originating in there. Then vastus intermedius, yes, the proximal shafts of what we call the femur anteriorly, vastus intermedius. Now remember I told you of the biceps, rectus femoris. I told you of the straight head and the reflected head taking attachment from what we call the pelvis. So that one is higher up. But these ones, which includes of course the vastus lateralis, vastus medialis, and vastus intermedius, which are part of the quadriceps muscle, which of course within the lower aspect of where the tendon, lower aspect of that tendon is where the patella develops, okay, will be originating on this femur. So these are some important bits that you should know. Yes, if you look at this one, what I want to show you is that, yes, if you look at the posterior aspects, of course, around where we have the linea aspera, now all those muscles will actually be originating there, except what we call the adductor muscles, adductor magnus, adductor longus, adductor brevis will be inserting there. So actually there's a mnemonic from lateral to medial. Yes, we have, yes, I love B, Mr. B loves me. So I love B. So from lateral to medial, I for intermedius, I for intermedius. So you can see, so from lateral to medial, yes, intermedius. So around where we have the pectineal, linea aspera, okay, from lateral to medial, the muscles we are going to insert there, which are going to attach there actually, will be of course the vastus intermedius. So I intermedius, vastus intermedius, and love is for vastus lateralis. B is for biceps femoris, okay, biceps femoris muscle. So I love B, intermedius, lateralis, biceps femoris. Then we go to Mr. B. So Mr. B for adductor magnus, okay. So Mr. B for adductor magnus muscle, okay. As you can see, adductor magnus then follows. Then of course, so I love B, Mr. B. B for brevis, adductor brevis. So adductor brevis then follows. Then we also have laughs for what we call adductor longus, okay, adductor longus muscle. So you can see adductor longus muscle, those ones will be inserted, the adductors will be inserted there. And then of course me for medialis, vastus medialis. So from lateral to medial, although they are, yes, roughly arranged over here, yes, if we are asked to arrange those muscles which are going to, yes, insert a posterior aspect of what we call the femur from lateral to medial, I love B, Mr. B loves me, okay. So I for intermedius, lateralis, biceps femoris, then Mr. for magnus, B for brevis, adductor magnus, adductor brevis, loves for longus, and then of course me is going to be vastus medialis. So that's what we are going to see over here. Then of course, if again, if you look at, yes, this intertrochanteric crest is not going to be aligned because we are looking at the posterior aspect. We are going to have the quadratus femoris also. Now this is quadratus femoris and not quadriceps femoris. Okay, so please get to know these important aspects. Then of course, if you look at the lower aspect too, yes, of course, this is the medial head of gastrocnemius muscle. Yes, of course, the lateral head will be here, yes, just above these condyles. That's where you're going to find them. Then of course, plantaris, yes, will become from lateral aspect and going medially. There's a plantaris, the muscle with the longest tendon in human body. So these are some, important bits that I want you to know. So there we are. I told you some muscles will be, yes, attaching on this greater trochanter. Yes, they include, of course, the piriformis, the superior gemellus, inferior gemellus, yes, the quadratus femoris muscle. Yes, all these ones will be inserting on the greater, what we call trochanter, greater trochanter. Okay, obturator internus. Okay, all those ones. All right, but I told you that lesser trochanter, iliopsoas tendon will be attaching there. Even on this one, we are going to have the gluteus medius, gluteus minimus. All these ones will be inserting here. Now, one thing that I want you to know is this muscle, which I call it the piriformis muscle. Now, this piriformis muscle, yes, although it is inserting there, is going to be an important landmark which we are going to use, so that, because we said that this piriformis will leave the pelvis through, of course, the greater sciatic foramen to insert on the greater trochanter of the femur, so that we can get two compartments, a suprapiriformis area where, of course, the superior gluteal nerve and vessels will arise, and then below it, inferior gluteal nerve and vessels will also arise. So what happens is that, yes, this piriformis also inferiorly is related to, of course, what you call the sciatic nerve. Sciatic nerve will be related to it, and then running on the medial aspect of the sciatic nerve will be this posterior cutaneous nerve of thigh. Now, one thing is that, yes, that's why we say that this piriformis muscle could be involved in, yes, this piriformis syndrome when it compresses on this, sciatic nerve. We are not doing these ones, but I just want you to have a feel of these ones. Now, but what do you see? You see that this is the iliotibial tract. Will be an important insertion point for, of course, the gluteus maximus muscle. Gluteus maximus muscle. Okay, so that's what we see. Also, by way of giving you some information about the ossification of what we call the femur, then the femur is going to have what we call 5 centers of ossification. It's going to have one primary center, which will appear around the 7th week of intrauterine life in utero. Then, of course, prosmally, it will have 3 secondary centers, and it's going to have the head, one on the head, which appears in the 1st year of intrauterine life. Then we also have one on the greater trochanter, which appears in the 4th year of intrauterine life. And then, of course, we are going to have one on what we call the lesser trochanter, which appears in the 12th year of postnatal. So 1, 4, 12. But the surprising thing is that all of them tend to fuse around the same year, around 18th year of postnatal life. So that is what we are going to actually see over here. Okay, now you know that this is a pressure epiphysis, that's why it's appearing first. These ones are traction epiphysis. Okay, so that is that. And then, of course, we are also going to have one secondary center in the distal end, and that one will appear around the 9th month. Okay, 9th month of intrauterine life. So just before birth, yes, that one will appear, and of course, will get fused around the 20th year of postnatal life. So 2 years, that one will fuse after the proximal ones have fused. So these are the things that I want you to know. So now, if you look at the patella, yes, the patella is actually a sesamoid bone. I told that it develops in the tendon of what we call the quadriceps tendon, and then, of course, extends inferior to insert on this tuberosity, which we call the tibial tuberosity. Okay, and that will be the patellar tendon or the patellar ligament. Now, this is a sesamoid bone. Yes, anteriorly it presents with this roughness, but posteriorly, if you look at it internally, it presents with 2 facets. The laterally placed one is larger compared to the medially placed one, although you can see it over here, and it presents with, of course, this is the base, and of course this is the apex. These are the lateral aspects of the bone. But what I'm interested in is that in runners, people who run a lot, yes, it means that there will be a lot of activity in this knee joint area, which means that the patella, yes, who actually track laterally. It won't track medially. It will actually track laterally, so that when it tracks laterally, that's what will result in what you call patellofemoral stress syndrome, and result in that kind of painful, sensation around this area. Okay, so that's what I want you to know. Now remember that this is the knee joint. The knee joint will be formed by the femur, of course, the tibia, and of course the patella. But this bone over here, yes, although it is giving some support to the joint, it is not contributing to this type of joint. Therefore, this proximal aspect, I'll have to explain to you, it is not a pressure epiphysis. I'll show you that. So these are the bones these are the bones. This is the two bones of the leg, which of course literally we can call them the shank bones. Now, so medially placed is the tibia, and then laterally placed is the slender bone fibula. Now, this bone tibia proximally presents with two condyles. Okay, so this is the medial condyle, the lateral condyle. It means that there's nothing on top of it, therefore it's devoid of epicondyles. Now, if you look at the superior surfaces of these ones, I'll show you that what happens is that you get to know that they are more or less concave, and they present with an intercondylar area, which of course will bear those kind of eminences. I'll show you that one. And then as you descend anteriorly, we are going to have this roughened area, and that's what we call the tibial tuberosity, which will project downwards as the anterior, tibial crest, or forming that forms what we call the anterior border, and that's what we call the shin. Okay, the shin. So of course, footballers will have to wear shin guard to protect this area. Okay, that's what we see. And then of course, because this bone is going to articulate with another bone, what happens is that, yes, by way of their shafts, apart from their proximal and distal ends, then there's going to be an interosseous membrane, and therefore there's going to be an interosseous border. So the interosseous border for the tibia, being a medial bone of the leg, will be laterally placed because it's going to articulate a lateral bone. Yes, if I take, all right, I will show you that one together. Now, then as I project, distally, on the medial aspect, I'll present with this protuberance over here, and that's what we call the medial malleolus. Medial malleolus. Okay, and then of course at the inferior aspect will be a facet for articulation with, of course, the talus to form the talocrural, joint. Now, what happens is that this time around, the proximal articulation points, okay, to form, of course, the proximal tibiofibular joint, and of course the distal articular point will both be provided by, of course, the tibia. So there will be a proximal fibular notch, a distal fibular notch, both on the tibia. Okay, so that's what we are going to see. But at the posterior aspect of the bone, we find a line, and that line is what we call the, soleal line. Soleal line. Now, let me give you some more information regarding this. Now, what do you see is that over here, this highlighted area, yes, this area, okay, will be the what we call the Geddes tubercle. We call it Geddes tubercle. Now, Geddes tubercle is very important. So where do you find Geddes tubercle? On the superolateral aspect, okay, anteriorly, on what we call the condyle of the tibia. We are going to have the Geddes tubercle, and it will be an insertion point for what we call the iliotibial tract. But similarly, just below this, medial condyle, just below it, there is another area over here, although it's not a tuberosity. Now, this area, which we call it the medial border, or the medial surface, actually medial surface of what we call the tibia, is actually subcutaneous. You can touch, you can feel this area. There's no muscle there. But as you get to the proximal aspect of the medial surface, it will provide, yes, attachment toward some muscles. We call them gyrus muscles. Gyrus muscles. Now, the surprising thing is that these gyrus muscles are originating from different compartments of the thigh. But at the end of the day, they are inserting around this common area. And these gyrus muscles are the most superficial muscles in all the three compartments of the thigh. Yes, so from the anterior compartment of the thigh, sartorius muscle; from the medial compartment of the thigh, gracilis muscle; and from the, of course, the posterior compartment of the thigh, semitendinosus muscle. All of them are going to insert here, and that's what I want you to know over here. Now, at the posterior aspect, we are having this line, and that's what we call the soleal line. Of course, the name tells you what it's going to do, so that one of the deep muscles of what we call the posterior compartment of the leg, being the soleus muscle, will, of course, will insert here. And of course, I hope you know that the soleus muscle can also be called the peripheral heart, okay, to help in those kind of venous return. Okay, so this is the origin for the, the origin for the soleus muscle. And then just above the origin for the soleus muscle, this highlighted area will be for what we call the what we call the yeah, that's the popliteus muscle actually inserting over here. Okay, originating, find its attachment over here, popliteus originating here. So that is that one for you. Let me show you something else. Now if you look at these bones, now if you look at the slender bone, yes, it's going to present with a proximal head. Okay, although I want to tell you that this proximal head is not a pressure epiphysis. Okay, I'll show you that. And then as you descend distally, yes, that's a shaft. Yes, we'll have a neck, a shaft, and of course it will present with this lateral malleolus. But because this bone is also going to articulate with another bone by way of interosseous membrane, then there's going to be a medial interosseous membrane border, because it's going to articulate with a medial bone. So this one will be interosseous border. And then of course we are also going to have an anterior, border. There's going to be an anterior border. And then of course there will also be a posterior border. So let me actually show you something. So this is the posterior aspect. So this is the posterior border. So if you take cross section through these bones, then what happens is that, yes, you can see the tibia. Yes, you have the anterior border forming the crest. It will have the medial border and of course lateral border. And of course you can get those respective surfaces. There will be a lateral surface, there will be a medial surface, and of course a posterior surface. And that's the interosseous membrane connecting them. And then so that will be the interosseous border for the fibula, and of course anterior border for, of course, the fibula, and of course there will be a posterior border and of course a medial border. And then it means that, yes, we are going to have those respective surfaces. There will be a medial surface, sorry, there will be a posterior surface, and then of course there will be a lateral surface, and of course there will be a medial surface around here. Okay, so that is what we are going to actually see regarding, of course, the fibula and tibia. Now remember that, yes, this kind of joint will not allow for pronation and supination, unlike in the case of radius and all that, where we had that kind of pivot joint, allowing for pronation and supination. In the leg region, we don't see such phenomena. Now, so if you look at the tibia, actually around where we have the intercondylar area, or just the superior view, yeah, this is going to be the anterior aspect because you can see the tibial tuberosity, and this will be the lateral aspect because you can see the head of the fibula around here. Then of course, yes, we are going to have in between. I told you that it's going to be concave in nature, and this concavity will be occupied by what we call medial and lateral menisci. So what happens is that this medial meniscus is lunar in shape, crescenteric shape, and this one is more circular. The lateral one is more circular. Then of course this area and these tubercles over here in the intercondylar eminence, okay, will provide respective attachment for, of course, anterior cruciate ligament and posterior cruciate ligament. So remember the nomenclature for these cruciate ligaments. When we looked at, of course, the knee joint, we got to know that, yes, the nomenclature is based on the attachment on the tibia and not on the femur, because on the femur it is exactly opposite. So anterior cruciate ligament, yes, the anterior tubercle over here and the posterior tubercle over here, providing the respective attachment. Yeah, so let's go to question number 3, and question number 3 says, which of the following is not true? Now option A says the weight bearing bone of the leg, being the tibia, present with a tuberosity anteriorly for insertion of the patellar ligament. Yes, we've already seen that. That's a very true statement. Option B says, unlike the forearm bones, both notches for articulation at the proximal and distal tibiofibular joints are provided by the tibia. That's also a very true statement. We've already seen that. Option C says, the slender bone fibula, whose secondary centers of ossification violate the law of ossification, bears a lateral epicondyle at its distal end and articulates with a tibia at its diaphysis via an Intrusious Membrane. Yeah, this is actually a very true statement. Yes, we get to know that, yes, we see the secondary ossification centers in both the tibia and fibula. We see that. And of course, one thing is that you're going to articulate to the tibia via an Intrusious Membrane. That's a very true statement. Option D says both the tibia and fibula take part in the formation of the ankle joint via their malleoli, but only the tibia partakes in the knee joint formation. We saw that it was only the tibia who partook in the formation of the knee joint, but the ankle joint, both malleoli, of the tibia and fibula all partake. Option E said the calcaneus is frequently referred to as the heel bone and provides insertion point to the Achilles tendon. Yeah, this is also a very true statement. So with respect to this question, yes, everything over here is actually true. Everything over here is true. So let's justify that now. So I begin with the ossification center. Yes, we've seen the bones of the leg being, of course, the tibia and of course the fibula. Now if you take the tibia, for instance, the tibia will present with, of course, one primary ossification center which appears in the 7th week of intrauterine life, and then it will have two secondary ossification centers, one in the proximal end which appears just after birth and fuses around age 17. Then one at the distal end, including its medial malleolus, will appear, yes, around the first year. So after the proximal secondary center has appeared, the one at the distal end will appear in the first year, and it will get fused around age 17 of postnatal life. So as this appears, this one appears. So just around the same year, then they will get fused. So that's what I want you to know over here. Now, there's a little bit of issue when it comes to that of the ossification with respect to the fibula, and that's why I've said that a secondary center of ossification violates the law of ossification. So with the primary center, after the tibia has has appeared, the primary center of ossification for, of course, the fibula will appear in a shaft. And then look at something. Rather, the distal end will appear first, in the first year. But of course, if you look at it, the proximal end of the tibia appeared before that of the distal end. But in this case, yes, for fibula, the distal end appears in the first year of postnatal life, and it will get fused around the 16th year. Then, of course, the proximal end appears in the 4th year of what we call the postnatal life, and it will get fused around the 18th year of postnatal life. So look at some. This is where the valuation comes in. Now the valuation is that if you are a secondary ossification center, if you appear first, you are the last to fuse. But look at it, at the distal end of the fibula, the secondary center appeared first, and it's also fusing first. And that's why we talk about violating the law of ossification, because if you appear first, you should fuse last, or if you fuse later. So the possible reason is that, yes, the distal end of the fibula is actually the pressure epiphysis and not the proximal end. The possible explanation to this, why this one is appearing first, is that, yes, it is a pressure epiphysis. And remember that we told you that, yes, pressure epiphysis will appear before traction epiphysis will appear. So that's why this is appearing first. But it is the first to fuse, because this is not the growing end of the bone. The growing end of the bone is at the opposite aspect, and that's why this is the last to fuse. Because if you remember, there's a mnemonic which we call it to the elbow I go, to the knee I flee. Now the elbow you saw that will be in the forearm. So elbow, for instance, if you look at the humerus, radius and ulna, they are what we call nutrient foramina, who we directed towards what we call the elbow joint, which means that the nutrient foramen of the humerus will be directed downwards, but the nutrient foramina of the radius and ulna will be directed upwards. But it's exactly opposite to what we find in the case of the knee joint. In the knee joint, there will be, of course, the femur will be here, and for the femur will, so we say to the elbow I go, to the knee I flee, so we are moving away from the knee. So the nutrient foramina, okay, on that of the femur, okay, will be directed upwards, and then the nutrient foramina on that of the tibia and fibula will be directed downwards. Now the principle is that if the nutrient foramen is directed downwards, then the growing end of the bone will be upwards. So that is why this one is the last to fuse, because that's the growing end of the bone. So please get to understand these ones. Now, by way of giving you some more information, it is actually the tibia, okay, the proximal aspect of the tibia, which is frequently affected with acute osteomyelitis, okay, that kind of bacterial infection over there. But the good news is that, okay, and usually occurs around where its epiphyseal plate is, and that one becomes, of course, after fusion becomes a epiphyseal line. The good news is that this acute osteomyelitis doesn't extend to the knee joint, because the joint capsule of the knee joint is proximally placed. So I want you to actually appreciate these ones. So this is some kind of important bits that you have to know over here. So I told you that, yes, these are the bones. Yes, there's the tibia, the fibula, there's the weight-bearing portion of the bone. The fibula is non-weight-bearing. Okay, and therefore, yes, we could actually, that's why it is frequently harvested, okay, for some kind of let me say transplant, okay, so that we can use maybe the bone marrow for something else, okay, some kind of grafting, because yes, the person will still be able to walk without this kind of fibula, okay, this kind of fibula, if we use it for that kind of grafting. So that is what I want you to know. These are the articular surfaces which are going to articulate with, of course, the talus of the leg region. Now what I want to show you over here is that, look at it. Now this is the Intrusious Membrane, which is more or less directed, yes, from the fibula to, of course, the tibia superiorly, in that manner. But look at it, at the initial aspect of this, before the formation of this Intrusious Membrane, is a triangular aperture over here, and this aperture is to give passage to what we call the anterior tibial nerve and vessels. So the anterior tibial nerve and vessels, which are going to, of course, supply the muscles in the anterior compartment of the leg, okay, will be actually emerging from the popliteal fossa to the anterior aspect. So will run in the anterior aspect of this Intrusious Membrane. Okay, those are the anterior tibial nerve and vessels. Okay, will be running this way. Sorry, anterior tibial vessels, actually the artery and, of course, the vein, not the nerve. Now what happens is that there's this nerve which we call it the common peroneal nerve. Now the common peroneal nerve doesn't come this way. You know that the anterior compartment of the leg muscles are supplied by, of course, the deep peroneal nerve, and then the lateral or the superficial peroneal nerve will be giving that kind of innervation to, of course, the lateral compartment of the leg. So actually coming this way, but not passing through this aperture, will be, of course, the common peroneal nerve. So it will run around the neck. The common peroneal nerve will run around the neck of this fibula. And then around that time, yes, just by wrapping around, then it gives off these branches, the tibial branch to supply muscles in the anterior compartment of the leg, and of course the lateral, the deep branch, deep peroneal nerve to supply, of course, the anterior compartment of the leg, and then the superficial peroneal nerve to supply the lateral compartment of the leg. But there's another thing too I want to show you. At the lower aspect, below the Intrusious Membrane, there's also a triangular aperture over there, and that one will give, passage for what we call the perforating branch of the peroneal artery, and that's what I want you to know over here. So there we are. I told you that, yes, there is this bone over here, that's the heel bone, okay, which will give attachment, provide attachment point. So this is the foot, actually, you will see it, provide attachment point for what we call the Achilles tendon or the calcaneal tendon, okay. That's one thing. And of course, if you look at the malleolus, okay, for the tibia, and malleolus for the fibula, they will both articulate with the leg, with the foot, through this talus, okay, through this talus. And remember, with the weight which will be transmitted, okay, onto the talus, most of it, about 60% will be distributed to the calcaneus, then the remaining 40%, yes, distributed the remaining portions, bones of the of the tarsus and that of the phalanges, sorry, metacarpals. Okay, so that's what we are going to see. But if you wear a high heel, then what happens is that you're transmitting most of the weight onto the other bones of the tarsus and of course the metatarsals. When that happens, then of course, yes, there's that kind of likelihood that you may have some kind of pain around these phalangeal areas. Okay, so that is what we are going to see. Let's go to question number 4. And question number 4 says, which of the following is not true about the foot bones? Option A says, unlike the carpal bones, which are organized into 2 rows, that of the tarsus are organized into 3 rows. Yes, this is a very true statement. Yes, this is a very true statement. We will see that. Option B says, both the metatarsals and phalanges are miniature long bones and present with a proximal base, intermediate shaft, and a distal head. Yes, this is actually a very true statement. You get to know the reason why they are miniature long bones is that, yes, they are presenting with a single functional, epiphysis. If there is another one, that one becomes an aberrant type of epiphysis. We will see that. Option C says, with the exception of the hallux, the remaining digates of the foot present with 3 bones, namely a proximal, middle, and a distal, phalanx. Now, that's a very true statement. Yes, so that's a very true statement. That's very true. Now, option D says the metatarsals and phalanges are convex superiorly. Yes, if you look at the shape, that's how the bones are curved. And if you take a superior view, they are convex. That's a very true statement. And option E says arches of the foot help to support the weight of the body, provide good distribution of the weight of the body over hard and soft tissues of the foot, and give leverage as one walks. Yes, this is actually a very true statement. This is a very true statement. So, actually, with respect to this question, yes, all those ones, yes, the remaining statement, all of them are true. Yes, so all of them are true. So let me justify that one for you. So there we are. Now, if you look at it, now this represents the skeleton of the foot. And if you take the skeleton of the foot, they are organized into 3 main bones. We have bones which are forming the carpal bones. Sorry, these are the tarsal bones, the tarsus. And then we also have the metatarsals, yes, beyond the tarsal bones. And then these are the phalanges forming the digates or the toes. Yes, toes over here. So if you take the superior view, which is a very good view for us, then we are going to say that the superior bone of the carpus is going to be the talus. Now remember, I told you that these bones are organized into 3 bones, 3 group of 3 rows, unlike in the case of the carpus where they were organized into 2 rows. So the 3 rows in the case of the foot are what we call the proximal row, okay, the proximal row, or we can say the posterior row. And this posterior row will include the superior bone, which is the tarsus, so the talus. And it is this talus which actually articulates with, of course, the malleoli of the fibula and tibia, okay, to form, of course, the ankle joint. So this is the one which receives the weight and then transmits about 60% to the next bone, which is also part of the proximal row bones, and that's the calcaneus, the heel bone. Okay, so this is the heel bone. All right. Now, one other thing that I want to show you over here is that the frequently fractured bone, yes, is actually, yes, this bone where is the talus. Yeah, sometimes even a calcaneus, but frequently is the talus. Now, this talus present with this neck. There's a neck over here. Now, this neck is separating the smaller portion anteriorly, and then the larger portion posteriorly. the neck, when this neck gets fractured, okay, what happens is that the blood supply to, of course, this proximal aspect of the bone is coming from the distal part. Okay, so from the distal part, it receives the blood supply, then gets to the proximal part. So it means that if there's a fracture, then what happens is that the proximal part, there will be no problem, but the larger distal part will suffer from avascular necrosis. Avascular necrosis. Please, that's what I want you to know over here. So these are the two row bones, proximal row bones. Then we go to the intermediate row. For the intermediate row, there's a single bone which is medially placed, okay, anterior to, of course, the talus, is what we call the navicular bone. The navicular bone over here. And then, of course, we also going to have the other rule, which is the distal rule. Now, for the distal rule, yes, from medial to lateral, we are going to have the cuneiform. So medial cuneiform, intermediate cuneiform, yes, of course, the lateral cuneiform, and of course cuboid. Okay, that's the distal rule bones of the tarsus. But of course, we say that the largest, cuneiform is, of course, the medial cuneiform, as you can see. And of course, the smallest is the intermediate cuneiform. And that gives the reason why the longest metatarsal is the second, metatarsal. Although we know that the first one is the strongest, the stoutest, as you can see over here. All right. So this metatarsal 1, 2, 3, 4, and 5. Okay. And all these metatarsals together with the phalanges that we are going to see will present with the proximal base, intermediate shaft, and a distal head. But what happens is that the functional epiphysis, and for that matter, where the secondary ossification center will appear in these metatarsals, will be in the head of these bones, except the first metatarsal, whose secondary ossification center will be in the base. And that is why we say that if there is going to be another secondary center in the head, in the first metatarsal, then that one is going to be an aberrant type of epiphysis. Similarly, if we're going to find these kind of secondary centers in the bases of the remaining metatarsals, that one will also be aberrant type of epiphysis. Okay, so that's what we are going to see. Now, and it is also the reason why this second metatarsal is the frequently fractured bone, and that fracture is usually what we call the March fracture. Now, March fracture usually will affect the metatarsal 2 and metatarsal 3. But a frequently fractured one is going to be the second metatarsal. And the reason is that, yes, it's the longest and it is the most fixed. Why is it the most fixed? You can see that there's more or less like a socket created over here, which tends to fix this bone quite deeply. Because, of course, this intermediate cuneiform is the smallest. So it means that this one have to come a bit more proximal. Okay, so that is what I want you to know over here. And then, of course, if you look at the metatarsals with the exception of the hallux, which will have two metatarsals, a proximal and a distal metatarsal, phalanges. The remaining digates will have 3 phalanges: proximal, intermediate, and distal phalanges. Okay, so now these are some important bits that I want you to know over here. Okay, now I told you that these bones, if you look at it, if you take an inferior view, these bones are usually curved, and for that matter, if you take an inferior view, they are concave, but if you take a superior view, they are convex. Okay, so that is what I want you to actually know over here. Now let's go to the last question for the day, and it says, which of the following is not true regarding the foot arches and the phalanges of the digates of the foot? So option A says the transverse arch of the foot is formed by the navicular bone, the 3 cuneiform bones, and the bases of all 5 metatarsals. Yeah, this is a very true statement. I'll show you that. Option B says the medial longitudinal arch is formed by the calcaneus, talus, navicular bone, the 3 cuneiforms, and the hairs of the medial 3 metatarsals. Yeah, this is a very true statement. I'm going to show you these ones. Option C says in the formation of the lateral longitudinal arch, the talus takes part. Okay, now there's a false statement. The talus does not take part in the formation of the lateral longitudinal, although medial longitudinal arch is going to take part. We will see that. Option D says pes planus and pes cavus are abnormalities associated with the arches of the foot. That's a very true statement. If you talk about pes, it has to do with foot, planus has to do with flat, and of course cavus has to do with high or something which is raised. Now option E says there are usually 2 interphalangeal joints, except in the case of the great toe where there are 3. Now there's a false statement. Yes, there are usually 2 interphalangeal joints, except the first one, which first to the great toe, which there are going to be only one. There's going to be only one. So it means in this statement 2 statements are false, option C and of course option E. So let's justify that. So there we are. Now we've seen the various, so these are the arches of the foot. I'm going to use this to explain the arches of the foot. So if you look at it now, we are going to have something we call transverse longitudinal, we are going to have 1 transverse arch, and we're going to have 2 longitudinal arches, a medial longitudinal arch and of course a lateral longitudinal arch. So let me use this one to start with the medial longitudinal arch. The medial longitudinal arch therefore will begin from the calcaneus, and then of course we'll come to the talus, okay, and then of course we'll come to navicular, okay. Then with respect to the navicular, yes, we'll go to of course the tracheiforms, okay. The tracheiforms will all be involved, okay. So here is this way: calcaneus, talus, navicular, all the tracheiforms will be involved. Then apart from that, what happens is that this time around is going to be, so it's running this way. This time around it's going to be the medial tray, the hairs of the medial tray metatarsals. So running in that manner, the hairs of the medial tray metatarsals, okay. So that's what we are going to see. But if you take the lateral longitudinal arch, you can see the talus is over here. So the talus is not part of it. Calcaneus is part. So we go to cuboid, okay. So we go to cuboid. Then you saw that we've seen that medial longitudinal arch was formed by navicular, yes, the cuneiforms. So calcaneus, cuboid. Then this time around, the hairs of what we call the lateral 2 metatarsals. Lateral 2 metatarsals. That's what we are going to see over here. But in the case of what we call the transverse arch, which will run transversely, okay, the transverse arch, that one will be formed by what we call the navicular, okay. So the navicular will be there, okay, this bone transversely, the navicular will be there. Yes, of course the tracheiforms will also contribute to it, okay, the tracheiforms. Then this time around we say the basis of all 5 metatarsals. So it's running this way: navicular, the tracheiforms, and the basis of all 5 metatarsals. The basis of all 5 metatarsals. Okay, so that is what we are going to actually see over here. Okay, so yeah, so that is that one. So these are the bones which are going to contribute in the formation of what we call the arches of the foot. Now, so with the arches, as you can see, so there's the medial longitudinal arch, there's the lateral longitudinal arch, and this is the transverse arch, the transverse arch. Now what happens is that if the medial longitudinal arch becomes too high, and that's what we call the high arch foot, that's the pes cavus. But when it becomes too flat, okay, too loose, that's the flat foot. Now, but if the transverse arch becomes too raised, then it may lead to some form of claw foot. Okay, so these are some important bits that we have to know. I hope you find us helpful. Thank you very much for your audience, but I want to use this opportunity to wish my father, Mr. Daniel Kofi Abam Okwan, a belated Father's Day. May the good Lord richly bless you, give you strength, so that yes, you can have a long, purposeful life. May God richly bless all of you for your audience.